I think it is 2 o'clock and we may wish to start.
I think so. Baturi.
Yes?
Hello, Dr. Baturi.
Yeah.
Can we check your phone?
Okay.
Good afternoon, everybody.
Good afternoon.
Yes, I want to be very. Thank you very much for joining us today. It's 2 o'clock. I'm thinking, do we wait an extra 5 minutes to see if we get more people joining us?
I think it's okay.
We have 11 participants now. I think we should just wait a while, see if more people will join us. Say 3 minutes or thereabouts.
Okay. Let's give it 5.
Yeah. Dr. Murtala, good afternoon, sir.
Good afternoon, Agassi. Good to see you.
Long time no see.
You've changed the whole wide web with your good thoughts and leadership style.
Thank you very much. Thank you very much.
Congratulations.
I'm very grateful. It's warming to hear that from you. I know most of you will not know. Dr. Murtala, I handed over to me. I was his secretary. I'm happy to have him here again with in YWF.
A pleasure.
And Dr. Murtala, good afternoon, sir.
Good afternoon, Agassi.
Yes, sir.
Good to see you.
You too,
Accidentally,
sir.
I'm in Casino.
Are you serious?
Dr. Ejike, good afternoon.
Good afternoon, sir.
Good afternoon. Every time I see Ejike, I like the way his hair shines. It's like he does something very special to that to that part of his head. I'm glad to have you here, Ejike. Very, very happy to have you with us. Okay, it's 2 minutes past 2 p.m. So 3 minutes left. Let's wait for another 3 minutes, or do we start now?
We have 17. I think let's just allow it 3 minutes.
So let's wait for another 3 minutes.
Yeah.
While we wait, I want to thank everybody who has joined us now. Your presence with us is not unappreciated. Your presence is what keeps YWF going and what makes YWF keep doing what YWF is doing. I want to thank you for coming to join us today. In a short while, we'll be starting. Just want to give 2 minutes extra before we start to allow people to join us. We are not unaware of the various issues we may have with our network connections at various parts of the country. So we want to see if we can allow some time for that. By default, participant videos, apart from panelists and audios, are turned off. Please keep your videos and audio turned off. Questions can be sent in through the chat section. And we'll be glad to take your questions. While we wait, I think it's just a minute left. I just want to remind us about our AGM coming up in a week. The Young Ophthalmologist Forum AGM be holding on Sunday, the 27th of September. It's going to be virtual on Zoom. And we're going to be having a business session and an academic section. Okay, so we have more participants joining us. So we'll be starting now. It's 5 minutes past 2. Good afternoon again, dear young ophthalmologists and guests. We want to thank you for joining us this afternoon on our second lecture series on the cataract series. The last time we took cataracts, we started our cataract series. Last lecture series we took was on patient selection and preparation and cataract surgery. Today we're talking about wound construction and capsulotomy, and we have to take us on this ride two ophthalmologists who have been part of the DNA of the Young Ophthalmologist Forum. This is why Young Ophthalmologist Forum was formed, to help nurture, grow, and to give back to young ophthalmologists. And one of our speakers was a one-time chairman of the Young Ophthalmologist Forum. I was his secretary, in the person of Dr. Murtala Umar. He's an ophthalmologist surgeon, vitreoretinal surgeon, and cataract surgeon in the National Eye Center, Kaduna. He is also the head, the Department of Community Ophthalmology of the National Eye Center. He's a teacher to many of us. He's taught a lot of us cataract surgery. And he also led us, like I said earlier, in the YOF. And Dr. Murtala, we are happy to have you with us. It is a thing of joy to see old YOs coming back to give back to the new YOs. It gives us this feeling of a continuity in chain of knowledge and progress. I want to thank you for joining us today, Dr. Murtala.
My pleasure, Dr. Cyril.
Yeah, our other speaker is Dr. Ejike Egbo, who is just like us, a YO like us. He's still within the YO bracket, but someone who has distinguished himself in the field of cataract surgery. Dr. Ejike has done well over 5,000 cataract surgeries, and he averages between 4 to 8 minutes per cataract surgical case. He had his training at Eleta Eye Institute and he is passionate about anterior segment surgeries. He's going to be taking us on capsulotomy today. He currently works at the Lilly Eye Hospital as their consultant ophthalmologist. Dr. Ejike, I want to welcome you. I want to thank you for joining us today.
Thank you very much. It's my pleasure. Happy to be.
Yes, I won't be moderating today. Yeah, thank you very much, Dr. Ejike. Our moderator is one who is well known to the YOs. It's going to be our secretary. Our secretary, Dr. Gochukwu Eze, is our moderator for today. He'll be guiding us and taking us alongside our panelists on today's session on cataract surgery. Dr. Gochukwu Eze is a consultant ophthalmologist in Katsina. And but I don't need to say so much about him. We all know him. So I will leave the floor now for Dr. Eze to start off. I want to once again ask that we keep our audios on mute and our videos off. By default, everybody is on mute and videos off. If you need to ask a question or say something, please use the chat function on your Zoom app. Thank you very much again, everybody. Dr. Eze, over to you.
Thank you, Dr. Cyril. Thank you, everybody that has joined this meeting today. Thank you for those who have joined us promptly, and we apologize for the few minutes we are taking to get things set. So now the meeting is about to start, and Dr. Cyril has made the first part of my job very easy and has introduced the guests. So our topic today it's wound construction in cataract surgery, Capsulorrhexis. So our first speaker today is Dr. Murtala, who has been introduced to us. He's going to take the first talk, which is on wound construction in cataract surgery, which is going to last for 20 minutes. After which Dr. Ejike will talk to us about Capsulorrhexis, Pitfalls, and Pitfalls, which also is expected to last for 20 minutes. Then we'll take questions and conclude. So Dr. Murtala, I think your screen is already being shared, sir. So I think we can take it on from there, sir.
Yeah, thank you very much. I want to congratulate YWeb for organizing a session like this, and I'm sure it will benefit a lot of the YWeb members. Now, when the patient comes to you as an ophthalmologist, he's coming probably because he has cataract, which we all know is one of the commonest causes of blindness. And what he wants is to restore his vision back. He doesn't know whether you are doing an SICS, a FACO, an ECC. Now, that is important because what is expected of us is to give the patient the best we can offer. I think that is key. The patient wants vision. This we must understand. Now, my concentration today is going to be on wound construction in SICS, because SICS seems to be the commonest cataract procedure we offer to our patients, especially as we all know, the cutoff VA for most of our cataracts in this part of the world is below 660. So most of them benefit from SICS. Now, talking about wound construction, ideally, when we do our biometry, we need to look at the K1 and K2. And this should guide us in the location of the wound itself. Most of us construct our wound in the superior part of the eye, but the K1 and K2, if the K1 and K2 is about the same, you could choose to whether you go temporally or superiorly. But if the K2 is less than the K1, or the K1 is less than the K2, it should inform the location of your incision. I think that is key. We need to pay attention to that. I'm also aware that some of the persons that have, the participants, are at different levels. There are probably persons who have not started cataract surgeries doing SICS. There are also persons who are more proficient than us choosing to give this lecture. So permit me to, I will consider this in giving my lectures. Now, basically, I think this should be more or less a discussion, not a lecture. And deliberately, I have refused to prepare any slide. Now, if you look at incisions, for example, now what guides you? Before then, what is an ideal incision? Because the whole idea is for you to have an incision that you are trying to contain astigmatism. You are trying to make sure that the physiological state of the eye is back in about few weeks, a matter of few weeks or so. You want to maintain your AC. You want to make sure at the end of the surgery, the anatomy is preserved. So the aim of your incision, in other words, whatever one is doing, because there are no, every surgeon is unique in his own way. When you are learning, you are guided on how to do one thing or the other. But one thing you must know is that whatever you are doing and you are getting results, and there are indicators that will tell you that you are getting those results. For example, if you've been doing SICS, constructing your wounds, and your number of patients who have prolapse are far less, your AC is most of the time maintained, then the chances that your wound construction is good is there. But at the same time, there's always room for improvement. Now, we all know that what guides you in, now, first of all, there are quite a number of incisions. As you can see here, this is more or less like a smile. If you take this as the limbus, this is the limbus, and then you can see this incision. It is parallel to the limbus. Now, this is a smile incision. It's usually not encouraged because the stability of the wound is not as good as the others. Now, when you look at this, most of us often do not do straight incisions. And then you have the anti-smile, which is frown incision. Now, these three incisions are all done most of the time. You find out that as a trainee or as a beginner, our incision falls between smile and straight. Now, what guides you in the distance? How the distance between the limbus and the incision? Usually people say you want to have 2.5 millimeters from the limbus. That's key. And then if you are doing a straight or a frown incision, now you look at your nucleus. The nucleus is important. When you look at your nucleus, if you have, for example, a nuclear cataract, you definitely need something like 6.5 to 7 millimeters of incision. But sometimes when you have a matured cataract that is probably milky, you may not need more than 6.5 to 5.5 millimeters of, incision, and that is key. Now, I don't know why you can see this orange. Now, I don't know, can we see this?
Yes, we can.
Now, good. Now, if you can see this orange, if you take this as your limbus, okay? If you take this as your limbus, and probably this is your 12 o'clock, let's use this as a straight incision. Now, this is a straight incision. You've looked at your nucleus, and it informs you of how much, what's the length of your incision. Should it be up to, the minimum length you must have is 5.5, because you are using the optic of most of our lenses. The least is usually 5.5. It's possible you could have others that are smaller than that. And of course, if you are doing an SICS with foldable IOL, you could go less than that. But often than not, if you are putting a PMMA, you need at least 5.5 millimeters of incision. Now that's one. Secondly, the nucleus or the type of cataract will also guide you in how much incision you should make. Most times you have 6.5 to 7. Now the distance between the limbus, the distance between the incision from the limbus matters, because the further away you are from the limbus, the less the astigmatism, but the more difficult, the more technical the surgery. So you need to have a fair distance, say 2.5 millimeters from the limbus. Now there are times that your incision will probably be less than that. So what you do in that case is you go more into the cornea. When you do that, it compensates. You're able to adjust for the, the distance of your incision to the limbus. Now, what I notice is that the first thing is, if you assume this is an eye, you must be stable as a surgeon. Your first incision, people use blades. Some people use surgical, razor blades. Some people use surgical blades, size 11. Some people also use even the sclera are different. There are patients, different types of skin. So you need to take note of that sclera. Half shouldn't also be too thick. When it's too superficial, the chances is that you buttonhole the sclera. While when it is too thick, you might have a premature entry. Now that is key. And I don't know what works for you, but what I found that works for me is that the way you handle the crescent knife is very important. When you handle this crescent knife this way, for example, it won't give you room to be able to do some maneuvers very well. So you need to handle the crescent knife a little, lower than half distance of the crescent. So you need to handle it well. This is very important, because a lot of people handle it wrongly, and that affects, their ability to construct a very good tunnel. So you must make sure you handle the crescent knife very well. And then when you made your half depth incision, so first of all, what I find working for me is that you open up the whole length of the incision. Open it. Don't just open at the, let's say at the center, and then you move it. No. Ensure that you open up from the beginning to the end, all stretch. Okay. Once that is done, you find out that you will not take a plane. You could go centrally, or you could go at either edge. Okay. Now you ensure that you do that at the same plane. Now, if you notice, it's a rhomboid shaped incision. Now, when you get to this cornea, you go a little bit into a clear cornea. Now, by the time you are sorry, I think there's a mistake here. This shouldn't be, it's supposed to be something like this. Okay. In other words, the incision into the cornea is wider than what you have outside. So when you get into the cornea, you need to change the shape, the orientation of your crescent knife. Now, often than not, you find out that people just go and then you continue. There's no way you have a rhomboid shaped incision unless you change the direction of the crescent knife, and then you cut in. Make sure you've cut in at least 9 to 10 millimeter within, while you have 6.5 to 7 outside. So you find out that you have a rhomboid shape. Now, when you now move to the other end, you also need to change the direction. So you must be seen to change the direction. You can see that if you are cutting like this, okay, by the time your tunnel is in, you are here. When you get here, you need to change the direction of the incision, okay? While at the other end too, you need to also change the direction of the incision. Now, you need to go a little bit into the cornea. Now, like I said earlier, if for any reason, there are times, if you're starting, you could use your caliper. There's nothing wrong in that to make sure you measure the distance from the limbus to the incision. You need to do that. But with time, you find out that you can estimate it. But there are times that even when you've been doing it, your incision is probably 1.5 millimeter away from the limbus. Now, if you don't go a little more into the cornea, you may not have a stable wound. So that's important. Always make sure you have at least 2.5 to 2.5 millimeters from the incision to the limbus, because the idea is sutureless, because by the time the intraocular pressure rises, it now closes the internal wound. And so you now have a stable eye, you now have a deep AC that can be maintained. Now, I think this is key. Now, when you are going into, so you've now made your tunnel and you are going into the anterior chamber, what do you do? Now, with your keratom, now you know the keratom are different sizes. With a fairly sized keratom like this might be 2.8, millimeters. So when you go in, then you change your orientation. So you're expected to just a little, once you go in, then make it parallel to the iris. I don't know whether you get me. You go into I'm talking of the internal wound now. If this is the limbus, this is the end of the cornea, you must have stripped the deciment a little. So you go in, as you are going in like this, you change the direction of, the blade, and let it be parallel to the iris. And now you cut in a direction towards one end, and then you now change and cut towards the other end. And you must make sure your wound is opened fully, because there are times that if the plane is not maintained, you probably have a half open wound, and when you are delivering your nucleus, it ends one into trouble. So in a nutshell, there are 3 types of incisions, and these incisions can be straight, can be smile, and can be anti-smile. Now the frown incision, I don't do frown incision most of the time, but I have seniors who do it, and theoretically, we all know that the frown incision gives you a better tunnel. Now, usually the frown incision, people go, it's usually anti-smile, because it's anti, the limbus is usually, it goes, against the limbus, and then you have this shape here, and then, so your tunnel will now, this will help in stabilizing the tunnel, the shape you have here. But I think that for a trainee, most trainees, what I will encourage is for people to be very conversant with the straight incision. And once you are conversant with that, as every surgeon is unique, like I said, you could now develop your own way of doing things. I don't know how much time I have. Dr. Eze, how much time do I have?
It's a remain 5 minutes. Okay,
good. Now, like I said earlier, the wound is important. Now, there are times you need to, the K1 and the K2, earlier, as I introduced earlier, should guide you in the position of your tunnel. Now, we all know that the K1 and K2 gives you the keratometric reading of the vertical and the horizontal, radius or diameter of the cornea. Now, when the K1 is almost K2, it means the astigmatism is not significant. And in such a case, you could choose to go temporal, you could choose to go, superiorly. But once the K2 is less than the K1, it means the horizontal axis is steeper. And as such, you could choose to walk in the superior, the superior limbus, And then for people who use sutures, because there are times you have to use suture, this is the case where you might need to tighten the suture a little so that it neutralizes the astigmatism at the temporal side of, you know, the limbus. Okay. Now, for the smile incision, the smile, if you start, you know, for beginners, most times you end up doing a smile incision because we've been used to ECC. In those days where people have to do a number of ECC before they graduate to SICS, we were doing more of a smile incision. Okay, and you find out that for people who've been doing that, that's why you see that most surgeons have graduated to SICS, but what you see, they may be getting it right, but what they are doing is smile incision. And that might be the reason for some of the prolapse you see. I tell people that when you do, if you construct your wound very well, maybe 1 in 100, you might probably have a prolapse. But prolapse is certainly not common if you're able to do a very good tunnel. Now, coming to the issue of putting a suture, I think it's more or less to do with personality. Sometimes, once you are sure of your tunnel, I think introducing a suture will probably be introducing an unnecessary astigmatism. But there are times where you have to put a suture because you have a very large nucleus, for example, that your incision is probably more than 7.5 millimeter, and you are not comfortable with that, because even when it's more than 7.5 millimeter, you're comfortable, your tunnel is well constructed, is rhomboid shape, you will not need any suture. But if you're not comfortable, there's no harm in putting a suture, but it's nice to go back and get that suture out. Because from experience, you find out that you've done a very beautiful surgery, you know, but the following day, the patient is having 660, 618, 624, and nothing explains that. But by the time you do a refraction, you find that the astigmatism is quite high. So I think the indicator that should inform us of whether we're doing well or not is how many prolapse do we usually have when we, you know, what is our wound gape? Do we usually have wound gapes? For example, you should be honest, look at the wound. Are there pencil signs most of the time? Are your wounds gaping most of the time? Because that could prone the patient to having, you know, infection that will probably lead to an endophthalmitis. So we need to be comfortable with every step. Every step is important. How much you go into the sclera in the wound, I mean, in making the first wound is important. It should be half thickness. And then you must make sure you maintain a single plane throughout and go into the cornea a little. And once you get to the end, change the direction of the crescent line such that you truly have that rhomboid shape, and then also change the direction of at the other end. And by the time you do that, you are well and good. So other entertain questions from participants later. Thank you very much.
Thank you for a very interesting and practical session you've led us through. I wish to inform our participants that they might send their question through the chat box. And after the next session, we are going to take questions. So at this point, we shall invite Dr. Ejike to continue from where Murtala stopped and talk to us about Capsulorrhexis. Dr. Ejike, sir, you have 20 minutes for the presentation, sir. Thank you.
Thank you. Thank you very much. Let me share my slide, my screen. Okay. Okay, thank you very much, Dr. Eze, for having me. I'm particularly interested in cataract and excited to make this presentation. And cataract is one topic that I will discuss any day, anytime. I'm appreciative to all my teachers for the experience I got while in training. So I'll do my presentation following this outline, and I hope I'm able to deliver a good presentation. I'll be standing on the shoulder of some giant experts in the field of pupil emulsification and cataract surgery. We don't have the benefit of a simulation lab or a practical session. So I'm going to share some videos towards the end of the lecture, and I hope that we are better informed. Okay, so by way of definition or description, continuous curvilinear capsulorrhexis is a method of creating and opening the anterior capsule of the lens that should allow for the removal of the cataract and then the implantation of an intraocular lens, rigid or foldable. It's been described by many teachers and surgeons as the rate limiting step in pupil emulsification surgery. I'd like to look at the brief history because one will ask, why did somebody go inventing or performing this procedure? It was actually popularized and by two ophthalmologists around the same period, Gimbel and Newman. So I was particularly impressed or interested in this statement given in Canada after performing more than 1,000 of these procedures in my practice. I made my first presentation of the concept rather, in a video titled The Continuous Tear Capsulotomy. The interest here is more than 1,000 cases. I haven't performed more than 1,000 cases of Capsulorrhexis, so I must say that we are still learning. Then some other person, Newham, coined the term Capsulorrhexis. The interest here is rhexis, which means a tear. It means to tear. And he also did a presentation at the German Society of Ophthalmology in 1985, where he described the technique. Some other persons who also contributed to the name of CCC. CCC is continuous curvilinear capsulorrhexis, so I mean, refer to CCC from time to time. The likes of Calvin Fercho and Kimaya Shimizu. So a lot of people have been, these are the originators of this procedure. And why capsulorrhexis? We want to ensure that we have a complete cycle without a radial tear. That's one. Two is to achieve centration of the intraocular lens, especially the foldable intraocular lens. And then while performing capsulorrhexis, the aim is to anchor the optic of the intraocular lens. Usually, like the last presenter did establish, most of the intraocular lenses measure about 6 millimeters in diameter. I'm talking of the optic now. So one rate a capsulorrhexis that is about 0.5 to 1 millimeters less than diameter of the optic of the intraocular lens. If it is too large, we may have iris capture. If it's too small, to lead to anterior capsule phimosis post-operative. So some of the tips for us will be, the challenge that we have is not really the procedure itself, it might be the setting of the microscope. So the microscope must be well adjusted, and then there should be a tilt of the patient's head, so that when the fluid doesn't flow towards you. So there's a slant of about 15 to 30 degrees, depending on the surgeon. I'm thinking of you adjusting the patient's head so that you can have a good view of the cataract and the eye generally. And then adjusting the microscope. We're worried about magnification. I think that the first two steps, when you're looking at the microscope, the first two steps are ideal for me. Those two work for me. My interest is to identify the anterior capsule and make sure I'm seeing very well. So it's important to, if the magnet is too small, then the rhexis will be fine, And if it's too big or too wide, the depth is less, and then the manipulation becomes more difficult. Then you have to inspect the instruments you're using for the rhexis. You're using a cystoscope, a bent needle, or the capsulorrhexis forceps. You have to inspect and make sure that the tip opposite So you'll be able to catch the anterior capsule and then tear. You must have a clear view, and then judicious use of viscoelastic device. Some surgeons who want to put viscoelastic device on the cornea, or I use saline actually. Then the pupil must be adequately dilated. And then even before we performing the procedure, the wound construction is very important. When you are doing the paracentesis, say for a 200 procedure, before you go with the fecal, with the, what do you call it, with the handpiece of the fecal machine, at the point where you're just entering, you want to stay with the trypan blue and all that. The incision shouldn't be wider than 2 mm. And then the side port, if you use side port, should just be about 2 mm, not wider, so that you maintain a good and deep anterior chamber. Because if your anterior chamber is already collapsing, before you go to perform go ahead to perform Capsulorrhexis, you are going to have a difficult time. So that's about wound control before you go Capsulorrhexis. And then capsule should be stained, these choices of viscoelastic device. Other preparation tips will be to inspect talk about that. Then steady fingers, very important. Movement in cataract surgery is with the fingers at the interphalangeal joints and not the wrist or elbow. So you have to lock your elbow and lock your wrist, then use the fingers. I don't know, for some reason, when I'm performing Capsulorrhexis, I find myself holding my breath, and I try not to breathe because the air that comes from your nose when you breathe kind of forms some form of condensation on the viewing piece of the microscope. So it may blur your vision. So somehow I find myself holding my breath. It could be because there's a difference in temperature between the room, the operating room, and then the air that is coming from my breath. So that can help so you don't have mist on the oculars of the microscope. Then for particular kinds of cataract, for soft cataract, the capsule is firmer, so it's easier to perform Rhexis on soft cataract. And then because you have a softer nucleus, even if it's not so wide, the Rhexis is not so wide, it's easy to aspirate all the content. Then for white cataracts are tricky. Some white cataracts are flaky, some have a hard nucleus, some maybe membranous cataract and things like that. So you have to actually decide how to go about handling a white cataract. Some of the videos I will share earlier, later on will throw more light on that. And then for milky cataracts, where we have liquefied cortex, it's advised some surgeons will puncture the capsule in the center to aspirate the milky content, and then visualize the nucleus and avoid rents of the posterior capsule. For brown and black cataracts, the anterior capsule is usually adherent to the cataract itself, and then when you stain with the trypan blue, it may not stay very well, so that will be more difficult. So I have some videos that I'm going to share with us. They're not my videos originally, they're from YouTube, but I found them very interesting. But before then, let me share my own video for my surgery on Thursday. I tried to, okay. If my microscope had recording facilities, it would have been better than this. So this is patient. It's not so clear, but please bear with me. I will pause it here. I don't know if you can see the Rhexis in the middle. Okay, so this is continuous curvilinear Capsulorrhexis on the patient. Okay, so having shared mine, let me now proceed to share with us. Okay, so let's just take some minutes to listen to what Dr. Devan has to say about. Okay.
Sorry, Dr. Ejike, your screen is not showing. You are sharing only the PowerPoint.
It's not showing? Sorry, is it?
What's the links?
How is it now? How is it now?
You are sharing only the PowerPoint. Stop sharing and share the whole screen again. Then we can be able to see your video.
Okay. Please just bear with me. Okay, let me unshare. Please bear with me. How do I go? Okay. That's, I'm trying to do this. Okay. I'm having difficulty.
Dr. Ejike, please, you could stop sharing the PowerPoint and then share the video screen. Stop sharing the PowerPoint.
Okay.
Yes. Then yes.
How is it now?
No, it's still not showing. You have to stop sharing. Stop sharing. Click.
Okay, I've stopped.
on
Okay.
Stop sharing.
I've stopped sharing.
Yeah, then share the video screen. Share the video now. Click on share. Now click on share screen and then pick the video screen.
All right.
Pick the video screen.
How is it now?
Let's see, it's about to come up. Aha, so it's, you have it, it's showing now. So you can start the video now. Thank you very much.
All right. Thank you, sorry for that. So these videos will just help because let us share this video.
Dr. Ejike, you may want to do a voiceover. Zoom may not allow secondary audio while you're sharing the screen.
Okay, so what's interesting in this video is we can see that this surgeon did not even stain the anterior capsule. What it tells us is that he has a very good view of the anterior capsule, which is one of the things I talked about. You must set your microscope very well to be able to see what you are doing. So that's what's happening here. And then he started from the center and is guiding the movement of the Capsulorrhexis forceps. So, and is able, and this is a soft cataract. The capsule is firmer, so it's easier to manipulate. And I was able to do that in about 3 movements. So let's complete the video. So, and you see how it's allowed for, and then the intraocular lens here is in, and the radius is about at least 0.5 mm less than the diameter of the optic of the intraocular lens. So this kind of capsulorrhexis will minimize intraocular astigmatism because it's holding the lens in place. There's no lens tilt. There's no retained cortical matter in the bag. So this patient is going to have a good outcome. So I will start this and play another one of the white cataract, and then I can appreciate that. If I have the, are we seeing the screen? Hello?
Yeah, you're good, you're
Okay.
good, you're good.
Right,
Screen is showing.
All right, thank you. So this patient, this surgeon is using blue. much respect to the producer of the video. This is a white cataract, somewhat flaky, may not have a hard nucleus. And you can see judicious use of viscoelastic material. Anterior chamber is well formed, and the wound construction here is almost 1 millimeter. Yeah. So what this surgery is doing is for a white cataract where the intracapsular pressure is high. You make a smaller rhexis and to relieve the intracapsular pressure. That's the capsule house between the anterior and the posterior capsule, the intracapsular pressure now. So a small rhexis will relieve that pressure, and then one tap, you tap on the cataract itself, and then you can even aspirate some of the cortical matter at that point to decompress to reduce the intracapsular pressure. That way, you won't have runaway capsulotomy. Like that, and that's a very common complication in big white cataracts. So that is what is happening in this video. So it's making a smaller capsulorrhexis in the center. Because, and also the capsule here is not so strong, it's not as firm as in immature cataract. So, good. It's decompressing the bag. So, that pressure. One interesting thing in this video is the wound construction this surgeon is making. It's a 3-planar incision. He first made a cut to the 15-degree blade, and then went about 90 degrees vertical. He now went in again 90 degrees horizontal, and by the time he's entering the anterior chamber, he's going at an angle of about 45 to 60 degrees. So you see that it is self-sealing. So there's no way the anterior chamber is going to collapse because the incision is small and it's three planes. So that's something I wanted to point out. Wound construction is very important because he's still going to work on the rhexis to widen it and be able to perform fecal emulsification. Okay. So at this point, he's going to increase the size of the rhexis by grabbing the caps at one end, making a tear, and then with guided movement, we will enlarge the size of this rhexis to about 6 millimeters. And that's what's happening. Make a cut. This is viscoelastic, been injected into the eye. there's something to note here. At each point, it looks like he's losing grip. He injects more viscoelastic material because the viscoelastic material stabilizes the capsule and then he's able to manipulate it. So the use of viscoelastic material, very important. And then another thing is we can see that this rexis is not necessarily round. It looked like it was heart shape. I'm trying to share my screen now. Let's try. Okay, share screen. So back to my presentation. Sorry. Okay, I'll find my screen. Sorry. Show overview. Okay. So can you see my screen now?
Yes.
Okay, so these are that's the video that's for some of the tips that were mentioned: soft cataracts, white cataracts, liquefied cortex, brown and black cataracts. So in summary, wound construction must be good, judicious use of viscoelastic material, adequate staining, and then the setup adjustment, set of microscope must be good. The procedure itself is not particularly difficult, and then people prefer, I prefer to use the bent needle. Others prefer Rexis forceps and then the system. So it's a matter of what you are comfortable with. But what's important is that we have to practice, do numbers, more numbers to get proficient. I will refer back to what Gimbel noted in describing CCC. He said, after performing more than 1,000 of these procedures. So we can't say we are proficient until we have done this over and over. And then we don't have to wait until we are doing emulsification to practice CCC. Even with manual sponge incision, we can practice CCC, and then we can even insert a rigid IOL. Thank you for having me in this presentation.
Okay, thank you very much, Dr. Ejike. Thank you very much, Dr. Murtala and Dr. Ejike, for keeping to time and for very practical and straight to the point presentation. I think this is time for question and answers. And we have a few questions from what I can see in the question and answer sections. So I'll take the questions. I'll ask all the questions. The questions are grouped, some for Dr. Murtala and some for Dr. Ejike. So I'll take Dr. Murtala's questions first. He will note them. I will also ask Dr. Ejike's own, after which they can respond to the questions. Okay, sir, for the questions for wound construction, I have a few questions here, which are, what are the indications, temporal approach in small incision cataract surgery? Hello, sir. Dr. Murtala, are you hearing me? Hello, sir. Hello.
His audio is not on. I think we should start with
Dr.
Dr.
Murtala
Ejike.
is having some technical difficulties.
Okay. Dr.
Maybe we
Ejike.
should start with Dr. Ejike.
Oh, yeah.
Okay. Dr. Ejike, we have a few questions here, which are, how do you manage an extension of the anterior capsule CCC when it's extended? How do you manage an anterior capsule CCC when it's extending into the posterior capsule? That's the question. Do you get it?
Yes, I do.
The second one is, how can one secure a runaway Capsulorrhexis? Then the next question is, what do you do when you have an Argentine flag sign?
Okay.
I think those are the 3 questions I spotted for you.
Okay. All right. Thank you. So these 3 questions are more related because I start with the first one. How do you manage a runaway? How do you manage Capsulorrhexis into the posterior capsule? Okay. To manage that, that's why I talked about. You have to anticipate it to be able to manage it. What kind of cataracts am I likely to? In what kind of cataract am I likely to have a runaway into the posterior capsule? It will be found it will be seen in cataracts that are like mature cataract, intermittent cataract, hypermature cataract, and the like. So anticipating that, what to do is, first of all, I will try to prevent it by using viscoelastic. But when it occurs and it is already involving the posterior capsule, what I will do if my posterior capsule is threatened is my first option will be to try an envelope capsulotomy. The second option is to convert to small incision, because the aim of the surgery is to give the patient a good outcome. So if my posterior capsule is threatened, I will convert to small incision and use a rigid IOL. Now, how to secure a runaway capsule? By the time the capsule is running, to prevent it is what I showed in one of the videos, or was showed in one of the videos, where you decompress the pressure in the bag. If the pressure in the bag is decompressed in mature cataract and intermittent cataract, a runaway capsulotomy is unlikely. If it's running and I'm seeing that it doesn't gotten to, I'm still seeing it doesn't run beyond the iris. At that point, what I will do is to instill viscoelastic. So I put pressure on it. Then you can go away from the point where it's running and start another rhexis that will join it. So in that case, my rhexis may not be very circular, but I wish I could draw something. Then, so that's how I will manage a runaway capsulating. Then the Argentine flag. The Argentine flag is that you have stained the anterior capsule is blue, white, blue. That's the Argentine flag. So you have stained the capsule blue, and then it divides. You're trying to do a capsulotomy, and then it divides in the middle so that this side is stained blue, and then the middle part you are seeing a white cataract, and then the other side is blue. If is so big, I will convert to, I'll create a tunnel and convert to small incision. The other thing I can do is what I described earlier on, do a rhexis that is further away from the initial rhexis and then join it more peripherally. So that's what how I want to think about the. But most important is to be judicious with the viscoelastic device to stabilize the cataract and the anterior capsule. Thank you.
Thank you very much, Ejike. Hello, Dr. Murtala. Are you here now?
If there's a problem with this audio that you cannot fix, maybe we can.
Yeah, I think.
Take some of the questions and.
Yeah, Dr. Ejike, I think let Dr. Ejike take some of the questions while we try to sort out Dr. Murtala's technical issue. Okay. He's having some issues joining us with his audio. We don't know if it's his device or his network connection in his area. So, okay. Dr. Ejike, if you don't mind, please, if you could take some of the questions while we try to sort out Dr. Murtala's technical issues. Thank you very much.
Okay. Okay. And I hereby read the questions. The first question is, what are the indications for temporal approach in small incision cataract surgery? Second question is, did you get the first one?
Yeah, indications for temporal approach.
Yes, sir.
Okay.
The next question is, what are the steps to a successful temporal approach?
Okay.
What are the steps for a successful temporal approach in small incision cataract surgery?
Okay.
The next question is, in case of a premature entry, how can one proceed with the surgery? In case of a premature entry into the AC, how can one proceed with the surgery?
Okay.
Question here is, which axis is represented by K1 and which axis is represented by K2 from our biometry?
Okay.
After
right.
the question,
Thank you very much for these questions. Are there more questions?
I think that's all for the questions.
Okay, so the first question is indications for temporal approach in small incision cataract surgery. Okay, now we must understand how cataract surgery, small incision, and then ECC affects astigmatism. Now, for ECC, I'll start with ECC and then talk about small incision and then talk about the temporal approach. For ECC, because we use sutures, the effect of those sutures increases for a superior incision. ECC is usually superior incision, superior corneal or superior limbal. Now, the effect of these sutures causes an increment in the convexity of the vertical axis of the cornea. That is inducing a withdrawal astigmatism. So, but in small incision, where we have a straight, we have a smile, we have a chevron incision. Those incisions actually relax astigmatism on the axis where they are placed. What I mean is, if you make an incision on the vertical axis superiorly, and it will relax with the rule astigmatism. Now, K1, K2. K1 is vertical, K2 is horizontal. If K1 is greater than K2, it means that the vertical is steeper than the horizontal. If the K2 is greater than K1, it means that what did I say? Sorry, let me take that back. If K1 is vertical, K2 is horizontal. If K1 is greater than K2, it means that the vertical is steeper than the horizontal. And if K2 is greater than K1, it means that the horizontal is steeper than the vertical. So what guides where to place the incision is which axis is steeper and which you hope to relax. So if I have K2 greater than K1, I'll do a temporal incision, which can be straight, can be crown, or chevron. So that's by way of answering the third question on what is K1 and K2. Then, in case of a premature entry, what to do? If there's a premature entry, the factors to take into consideration are: one, what distance you have between the limbus and then your incision. Typically, incisions should be at least 2 millimeters from the limbus. Now, if the incision is less than 2 millimeters from the limbus, it will be difficult to manage. And then, what's the size of the premature entry? If it is an entry less than 2 millimeters, what I will do, or what one can do, is to leave that point of the entry, go to the side, and start a new tunnel. This tunnel will now go above the place you had the entry and onto the other side, and then you can complete your surgery. If the premature entry is too wide, up to 3 to 4 millimeters, then you may just maintain the same plane. We are going to struggle with iris, but the iris will collapse. But you just widen the incision up to 6 millimeters, perform the cataract surgery, and then put sutures. So you have to learn, managing the iris will be a problem. And then delivering the nucleus is difficult, so we may have to do, use what is this instrument? I usually use visco to deliver. You get vectors. You might need to do a vector delivery of the nucleus because of iris that will be in the tunnel. So that's how to manage a premature entry in small incision cataract surgery. I don't know. Okay, there's another question. Any other question?
Steps to a successful temporal approach.
Okay, the steps to a successful temporal approach. Well, the steps are almost the same for superior or temporal. The only thing is that we are used to the superior, and in the superior approach, the patient's head is closer to your chest, and everybody is used to it. Unlike the temporal approach, where the shoulder creates a greater distance between the surgeon and the eye of the patient. And then I think the temporal sclera is also thinner than the superior sclera. So basically, if you are well positioned and you can manage that distance, I think the steps are essentially the same. But for steps for if you're talking about steps for creating making a good incision or creating a good tunnel, the first will be to do the cautery. The area you're going to create where the wound is going to be has to be clear. And then I use crescent for my tunnel. The crescent has a sharp edge for the vertical incision at 90 degrees, and then tunnel horizontally at 90 degrees to the vertical. And then the tip of the crescent should point upwards and not downwards. That way you avoid entering the anterior chamber inadvertently. And then, like Dr. Umar explained why he was talking about, a tunnel all the way, all the length, if it's a 5 millimeter incision you've made of 4 millimeters, the tunnel all the way and progress into the cornea about 1 millimeter. So I think those are the steps.
Okay. Thank you very much, Dr. Ejike. We have one more question here. We have one more question here that came in after the question and answer session started. So what is Little's maneuver and how effective it is? Is it?
What is?
And how effective is it?
Little's maneuver.
Yes, sir.
Little. I'm not very sure I know, but Little's maneuver, what, if it can be described, maybe I have an idea of what it is.
Okay. No, I don't think we might be able to describe it on this forum. Perhaps.
Okay.
Okay. Thank you very much for the question and the question you anchored for us, and also standing in for our teacher, Dr. Murtala. One of our a senior member of our forum too, is he has been raising his hand while Dr. Ejike was asking a question. In the person of Dr. Sadiq Abdullahi, I think we'll allow him 3 minutes to make his contribution on Rhexis.
Thank you very much, Dr. Eze, for allowing me to make a contribution.
Thank you, sir. Welcome, sir.
I must say that the speakers have done very well on this topic, and I just have a little point I want to add, especially with regards to Rhexis. Actually, YOF is doing a great job. It's taking the discourse on cataract to a higher level, and Rhexis is one of the left to me is one of the things that we'll be doing for every cataract patients. And one of the advantage of Rhexis is that you can be sure the lens should be placed in the back. And if you have any complication like fissurance, you have the advantage of the capsular support where you can place the lens in distal course. And then when you are doing Rexis, I have a little things to see. There's what is called danger zone. Danger zone are the point at which Rexis extension is likely to happen. And these are the same cardinal 12 o'clock, 6 o'clock, 3 o'clock, and 9 o'clock position. So when you're going around at those points, you have to be very careful. And it was regards to Rexis extension. Of course, when you have Rexis extension, one of the way that you can, in addition to starting Rexis from another part and then joining at the point of the extensions, you can as well make a direct pull on the Rexis toward the center of the nucleus. For example, when Rex is trying to extend at 6 o'clock position, you can put a lot of gels, flat the Rexis flap, and then pull it directly toward the center, that means toward the 12 o'clock position. And in this way, you can see that the Rexis extensions can be managed. But basically, when you're doing Rexis, how to prevent extension is that always anterior chamber should be formed. You must, and this the shallowing of the AC can be prevented by, like what Dr. Ejike said, that small incisions. When you are making side port, make it small. When you're making entry points, make it small. Trap as much visco as possible within the AC. And one of the indications that the AC is becoming flat is when you see the Rexis is trying to stand. It's not lying flat. So immediately you see the flap is trying to raise up, you have to put gel and make it flat. Once it is always flat, you see that you don't have much problem. And then with regards to white cataract, like what you have actually stated, you also need to consider double Rexis, or you can do spiral Rexis in case of patients that have intermittent cataract. You make a small Rexis and then you make a second Rexis again, and you enlarge because of the risks of the Argentine plaque. So basically, these are the things I want to emphasize. 1, danger zone. 2, 90-degree pull toward the center. And 3, AC should always be formed. And then 3, in a patient with white cataract, you can do double or spiral Rexis. But I think overall, he has done very well on this topic.
Thank you very much, Dr. for your input. You've given us a new insight and dear YOs, dear participants, want to appreciate you for being with us up to this stage in the presentations and our webinar. I'm going to take a short synopsis of what has happened today so far, after which we'll take an announcement from the chairman and this session will close. So we had 2 presenters, Dr. Murtala and Dr. Ejike, and they gave us quite very practical sessions. I'll try not to be seen to be repeating what the speakers had said, but I'll just make a few highlights. Dr. Murtala pointed out that in our environment, that small incision is still very, very relevant to meet the cataract surgery need for people in this world. And he stated that there are 3 types of incisions. We have the smile, the straight, and the frown incision. He equally, while he was presenting, he kept in mind that there are different participants at different level of cataract surgery, and he tried to maintain his discussion as basic as possible to cater for those that are quite beginning, and left it open for those who are more advanced in cataract surgery. You know that every surgeon is unique, and while going through the learning curve of cataract surgery, it's good for one to pick what works for him while he's being supervised and while he's having his surgeries, and he picks what works for him and stick to it. However, while sticking to what works for one should also be willing and open to learning new things. For example, when one have found himself that is successfully doing can't-open capsulotomy, we should be ready to know when to start accepting new teachings, to start to commence can opener Capsulorrhexis. He went ahead to tell us a few things to consider to have a good wound, incision, because the topic was wound incision. The topic was wound creation in small cataract surgery. Then ideally, the wound, our incision in 6 should be between 6.5 to 7.5 millimeters. How based on experience, size and nature of the nucleus. Very large and hard nucleus, it's good to have the wound as large as possible, for which the wound might be up to 7 or 7.5 millimeters. But for nucleus that are soft, there may be no need to have it even up to 6.5 millimeters, because it will be easy to handle the nucleus and aspirate it. Also pointed that when we are using PMMA lens, it's good to know that our nucleus, our wound incision should be at least 6.5 millimeters. And indications for us to know that, or for a surgeon to know that he has a good wound at the end of his surgery, and why he audits himself, his number of prolapse that he encounters at the end of his surgery, or why he does his post-op evaluation. Also, presence of wound gape. Also, presence of wound gape also should be something that the surgeon should consider. And also from experience, also the presence of wound gape, and also the surgeon should be ready to use as much visco as possible to maintain a clear cornea. Dr. Ejike went ahead to talk to us, summarize a few things for us about Capsulorrhexis, which he said that the first step to a good Capsulorrhexis is a good wound construction. After a good wound construction, it will be good to adjust the microscope to have as clear as possible, to have a clear view of the anterior capsule as possible. Also, it's good to inspect the instruments to know which ones can be used to manipulate the tissues as much as possible. The judicious use of visco he listed as part of the steps for a good CCC. Also, a stable anterior chamber and staining of the anterior capsule is very important. He also mentioned about steady fingers, and he went ahead to share a few videos for us to press his points. At this point, I will leave the floor open for the chairman to give us a few announcements.
Thank you very much, Dr. Eze. I want to especially thank our panelists, Dr. Ejike Egbo and Dr. Murtala Umar. Dr. Murtala Umar has just joined us. Finally, we're going to sort out his technical issues. He's back with audio. It was some network issues on his end. I want to thank you once again for joining us. I want to thank every YO that has joined us today. Your presence and your journey with us is what's made YOF the way it is. Without you, we would not have been able to achieve anything. We have one more lecture series in the cataract surgical series on phacoemulsification. Following that, we will then move on to the glaucoma lecture series, surgical glaucoma lecture series, where we would talk about cataract surgery and glaucoma in glaucoma patients and other glaucoma surgeries. We have a lot of YO members and SYO members who are doing very, very well in the glaucoma field and are itching to give us practical sessions. As usual, our sessions will be as practical as you found our previous cataract surgical sessions. And we will try as much as possible to do away with a lot of theoretical outputs and do more practical sessions like we've been doing. Just to remind us also that we have our AGM coming up on Sunday, the 27th of September by 2 p.m. The business session kicks off by the academic session kicks off by 2 p.m. And we're going to be having two faculties. Dr. Ejike Ajayi will be joining us. He'll be giving us some tips on our business of eye care practice series. If you recall, last month we had our first lecture series in the business of eye care, where we talked about opening and running a private eye care practice. Dr. Ejike Ajayi will be continuing that series and be giving us a lecture on equipment, procuring equipment in your practice. He'll be going to be giving us tips, priorities, and then teaching us how to make our pockets work for us. We do understand that ophthalmic equipments are super expensive and our resources are limited. So he's going to be teaching us how to use our limited resources to meet our needs for meet our needs for quality eye care at very little cost with very little recurring overhead. Also, our second panelist is Dr. Ejike from the United States of America, who will be teaching us, telling us and giving us stuff on compliance, making compliance effective among glaucoma patients in low resource economy like Nigeria. Vivian Ejike started her practice in Nigeria before moving outside the country. The academic session, excuse me, the academic session attracts a 5 CME points, courtesy of the Nigerian Medical Association. So every attendee, if you request for it, you would have a stamped and signed 5 CME points for the academic session. Our business session will follow thereafter, where we'll be x-raying the past 1 year of the YOF calendar and looking forward to the next 1 year and hoping that our next 1 year will culminate in a physical meeting at the next OSN AGM in 2021. I want to thank every one of us again. I want to thank our panelists, Dr. Murtala Umar and Dr. Ejike Egbo, taking time out to join us and to share practical tips on cataract surgery. I also want to thank the academic committee for rallying around and putting this together, spearheaded by Drs. Bature and Drs. Yeye Agba Olabisi. I want to thank you very much for doing all this for YOF. And we hope that we continue to do this to the benefit of young ophthalmologists in Nigeria and to the betterment of ophthalmology practice in Nigeria. I will thank you guys once again. I think the meeting officially has come to an end. We try to keep the meeting within 1 hour, 30 minutes. I think we have succeeded in doing that. I want to thank you very much. I can't stop saying thank you. Please don't mind me. So let me thank you once more for the last time. Thank you very much for joining us. And I think we can end the meeting now. Thank you very much once again.
Thank you. Thank you, Mr. Chairman. Thank you, participants.